Neck dissection is a surgical procedure performed to remove lymph nodes and surrounding tissue to treat or prevent the spread of cancer in the head and neck region. It is categorized based on the extent and purpose of the procedure. Below is a detailed description of the different types of neck dissection. 1. Radical neck dissection, RND. This is the most extensive type of neck dissection. It involves the removal of all lymph node groups in levels IV, submental, submandibular, jugular, and posterior triangle regions. Non-lymphatic structures, spinal accessory nerve, cranial nerve exsiane, sternocleidomastoid muscle, SCM, internal jugular vein, IJV. Indications: advanced head and neck cancers with extensive nodal involvement, cases where the tumor invades non-lymphatic structures. Consequences: shoulder dysfunction due to spinal accessory nerve removal, cosmetic deformity from loss of SCM and IJV. 2. Modified radical neck dissection, MRND. This procedure aims to preserve one or more non-lymphatic structures that are removed in radical neck dissection. Types: Type preserves the spinal accessory nerve. Type 2 preserves the spinal accessory nerve and internal jugular vein. Type 3 preserves the spinal accessory nerve, internal jugular vein, and SCM. Indications: cases where lymph nodes are involved but non-lymphatic structures are not invaded. Advantages: reduces functional and cosmetic morbidity compared to RND. 3. Selective neck dissection, SND. This involves removing only specific lymph node groups at risk of metastatic disease, sparing uninvolved levels. Common types: SND. Removal of levels 2 and 3, typically for oral cavity cancers. SND 2-4, removal of levels 2, 3, and IV, commonly for oropharyngeal, hypopharyngeal, and laryngeal cancers. Posterolateral SND, removal of posterior triangle nodes and occipital nodes, rare indications such as skin cancer. Supraomohyoid SND, removal of levels to 3, specific for cancers of the oral cavity. Indications: early-stage cancers with a low risk of extensive nodal involvement. Salvage surgery for specific recurrence patterns. Advantages: minimizes surgical morbidity by sparing unaffected nodes and non-lymphatic structures. 4. Extended neck dissection, END. This is a radical neck dissection extended to include additional lymph nodes or structures not typically removed in RND. Examples: removal of parapharyngeal nodes, mediastinal nodes, or the hypoglossal nerve. May include resection of the carotid artery, vagus nerve, or other adjacent structures depending on tumor invasion. Indications: advanced cancers with extracapsular spread or direct invasion into adjacent tissues. Consequences: increased risk of severe functional and cosmetic impairment. 5. Functional neck dissection, FND. This is a variant of selective or modified radical neck dissection designed to preserve function while achieving oncological control. Preserved structures, spinal accessory nerve, SCM, and IJV are preserved wherever possible. Indications: early-stage cancers where extensive nodal involvement is not suspected. Lymph node levels. Understanding lymph node levels is critical for planning neck dissections. Level 1, submental and submandibular nodes. Level 2, upper jugular nodes. Level 3, mid-jugular nodes. Level 4, lower jugular nodes. Level V, posterior triangle nodes. Level VIX, pretracheal and paratracheal nodes. Conclusion: the choice of neck dissection type depends on the primary tumor's location and stage, the extent of nodal involvement, the need to preserve function and appearance while achieving oncological control. Advances in imaging, sentinel lymph node biopsy, and targeted therapy have refined indications for neck dissection, reducing its morbidity without compromising outcomes.